Hello to everyone. I will share our experience from the Heidelberg University Hospital regarding the implementation of Align RT Advanced in our workflows, and especially out the postural module that has a video function, how it helps us to reduce the workload and increase the patient safety. A quick overview how the technology works, the main applications, which are the main applications at the Heidelberg University Hospital. Also a quick overview, which are the requirements to start using Align surface guided in your facility, which are requirements to a safe implementation of Align RT in your clinic. Then I will move for the postural module evaluation. That means how the workflow is affected, the patient setup, safety, and some unexpected applications of this technology. So, how can be Align RT applied clinically? So everyone knows that is how the technology works, but how can that in the clinical routine be applied? So first you have an extra safety measure because you have a TICOM coordinates your ISO center information in the system, so you can confirm if you are placing the patient at the correct ISO center position. Then instead of the 3 points, you can set up the patients using 20,000 points. That means that you have a lot of information compared with the old positioning method. So because you have a lot of information, you can define regions of interests, ROIs, and these ROIs are the ones that are used to set up and to confirm the position of the patient. Because the patient anatomy, the tumor anatomy can be different comparing with the surface of the patient. So we still need to do imaging for several cases, and we can define a correlation between the surface of the patient and the imaging when we do a reference of the treatment session at the same time that you do some kind of KV-MV imaging. So the big advantage of surface guided that you have a continuous monitoring of the patient. So you can in real time during the entire treatment to compare your reference surface, that means your planning CT surface, for example, and the current position of the patient during the entire radiation. That means including the imaging part and also irradiation, and this time between the imaging and the irradiation. So then you can confirm if the position of the patient that you accepted during the imaging session is the same that you have during the radiation itself. So there are several applications where you can use surface guided radiation therapy. And some of these applications that we notice more that now with the Align RT Advanced have more weight comparing with the applications that we had before. For example, positioning, you can positionate the patient using Align RT from head to extremities now quite easily using the video postural module. You can also confirm, you can assess interfractional variations on the patient, weight loss chances, and everything without additional dose to the patient. You can, during the treatment, confirm the breathing chances, evaluate the breathing chances variations, and some additional motion during the treatment. And also the patient safety is a really important point from my point of view, is one of the main reasons why surface guided have a big impact in the clinical routine, because you can confirm if the mobilization devices are correct, the position itself of the mobilization devices, if it's the correct patient that you have in room, and you don't need additional doses for any of these checks. And then you can also use the surface of the patient to do free breathing, gating, or deep inspiration breath hold technique. At the Heidelberg University Hospital, we started in 2016 with the first patients. We have currently the system installed at 2 Linacs and 1 sitting room. In this case, it's only for the training of the patients. And the system is also installed at the heavy iron facility. Currently, the main indication is still breast in deep inspiration breath hold. Looking for our statistic from the last years, the breast was really the main indication, with around 200 cases per year. That means that 200 patients per year were treated, each patient with around 20 fractions. In the last years, we started treating in other locations using surface guided to position the patient, and that is also now again increasing with the upgrade to Align RT Advanced in the end of the last year. So regarding deep inspiration breath hold applications, the main indication, as I said in the beginning, was breast, left breast. But currently now we are using also for a right breast, or every kind of breast that you have in simultaneous integrated boost, when you have a highly modulated VMAT plan that you need to increase your robustness, the robustness of your treatment. Also for the cases where you have a very thin thorax wall, some liver and lung tumors, and you want to do deep inspiration breath hold to save some doses to the healthy tissues, and some special cases has a heart irradiation, for example. Regarding the first feedback that we can give about Align RT Advanced. So Align RT Advanced really force to standardize your workflows. That means that you reduce the variability between each RTT. So the RTT are now forced by the software to position the patient with the same degree of accuracy. That means that everyone will look for the pitch, for the roll, for the 6th degree of freedoms, how to set up the patients the most accurately way as possible. Not only the information that you have in the Conbeam CT. Although you increase the standardization of your workflow is really patient specific. That means that the patient anatomy, you really consider it for each treatment. So each patient needs to have, for example, a slightly different ROI to consider the anatomy, the tumor location, and the tolerance can be also different depending of the plan quality. Also the skin tone need to be considered. So it means that although you really have a standard workflow, is always really patient individualized the treatment. That means that also during the first treatment session, we still need some additional time to adapt the treatment for each patient, to have the most individualized treatment delivery. That means that you also need a multidisciplinary team where the physicist, physician, and RTT need to discuss and adapt the treatment for each patient in a way to be to increase to reduce the workload and increase the patient safety. Something that we detect in the first after the first patients using the Align RT Advanced, that we reduce the need to imaging repetition. That means that we position the patients using Align RT, and after the first Conbeam CT, only small variations in translational are still necessary, but you don't need to adjust the patient so much that you need to perform a second Conbeam CT to confirm the position of the patient. It's also possible to reduce the imaging along the treatment course. For example, for the breast patients, where we do once a week imaging, and in general, you always need we always need less time for the imaging registration. So when the patient is positioned using a line RT and you do a combined CT, KV, or the MV imaging, then you need less time to register the image and to match the image. So it's also important to focus that because we are now using a new kind of technology to position the patient, to set up the patients, that some new questions appear. For example, how should we define the tolerance for each region of the body? Which regions are important? For example, in the example of a breast irradiation, should I consider the arm always, sometimes? How should I consider which tolerance for the arm? Is the arm ROI for a patient the same than for the other patient? Should I consider the breast, the entire breast position, or is enough if I only consider the breathing signal? What should I do if the patient moves during the treatment? That is a question that before, the time that you are not using surface guided, we never look for that, because you do a community and you believe that the patient is in the same position after 3-4 minutes, and you radiate the patient considering that he's in the same position than 5 minutes before. So what should we do now if the patient moves? Should we move the table? So move the patient? And that is something that now is also easy when you are using Align RT Advanced, because now with the video function, you see that the patient is outside tolerance, and you can easily detect why, where is the arm that is moved, is the patient not more in breath hold, is something different in the room. That means that is also the reason why Align RT Advanced motivated our RTTs and our physicians to use more surface guided to set up the patients, because they feel that is an additional safety measure that doesn't cost any dose, any time, because you only need to turn on the system, and then is almost automatically you start looking for the video and positioning the patient according with your planning CT. So that means that we are expecting workflow improvements. Some improvements is after 5 months you can already detect that you see the need to use Align RT for more cases, for most patients, where it's difficult to, for example, for the cases where it's really difficult to position the patients. Some cases that before you always do a plan with a large PTV margins, and you are compromising sometimes the risk organs because you are not able to set up the patients correctly every day the same. Now you are able with Align RT to see and to monitor the treatment and to monitor the position to have the same degree of quality every day. It's important that if you don't have Align RT in your clinic, that you to implement this kind of technology, that you need to have a multidisciplinary team. And they need to be motivated to break with habits, because the entire training of your staff was previously performed using 3 points to align the patients during multiple combi stages per day if necessary. So that means that you need to adapt your mindset, and you need to break with these old habits. That means that a multidisciplinary team where RTTs, physician and physicist works together to define a workflow is really the most important step. Of course, that you need to dedicate some time to commissioning, some LINAC time, so that you understand how your system works, and using these informations, you can then adapt your workflows to define your training for the entire team, and dedicate also some LINAC time for your training. Documentation is really important, and also some risk assessment of the new technology that you are implementing in your clinic, because it's a new way of work, so you need to have sure that your entire workflow and everyone know how works the positioning and the treatment using surface guided. So looking for the clinical evaluations of this new module. So looking for the video postural module. So the video is like a third or the second RTT that you have in room. That means that the video will confirm and will give you a quick overview if you are placing the patient in the correct position. If you are placing, for example, the immobilization devices correctly. If something is wrong, you can easily have a look to the video function and confirm if you need to change something and how to change, for example, the arm position of or the breast. So that means that one of the important points that now appear with Align RT Advanced, that you can improve your safety. You can use Align RT Advanced for patient identification, control of the immobilization devices, the positioning double check, so like a second RTT in room. You can also have a constant monitoring of the patient and confirm if between the time that the RTT placed the patient in the perfect position and the time that the RTT go outside and press the button to start the treatment, there was no variations, no changes in the patient position. So regarding the patient identification, that was something that we are not aware in the beginning, but then it's quite automatic that you look for the patient in the mosaic, for example, and you match and you look for the person that you have in Align RT. And because of this photorealistic quality, you really quite often can distinguish if you have another patient in room. Also, because you have this video with high definition, you can also with this video quality, and you can see quite well. In this case of this picture is a phantom, it's not a patient. You can see quite well the patient face and compare with the information that you have in mosaic. Also, a point that was always something that we had in our workflow, that each patient anatomy is unique. That means that it's quite difficult to match a breast of one patient with a breast with another patient. That means that it's also kind of patient identification tool without costing extra dose. Looking for the immobilization devices. So, for example, for the case of head and neck patients, where you use the head step. So when the RTT are in the room, placing the positioning the patient can be directly detected if you don't have the correct head step position. For example, if you have a different pitch, and then you can directly correct this position without costing extra dose to the patient, without waiting for the CT and detect, oh, I put in the wrong position. Also for thorax and breast, when you are using the wing step, for example, immobilization device, you can detect if the wing step position is correct, if the arms are correct, directly in room, and that saves, of course, several minutes. For the patients that you need to use abdominal compression, also the plate position and the pressure that is between the press and the patient, you can also adjust that the positioning along the setup time, and then that means it also save some time again, because then you only need to do a cone-beam CT and you've confirmed that you have the correct, exactly the same position than in the planning CT. Something new that before was quite difficult is for this kind of patients that you have a really individualized setup devices. So in the case that patients that have pain and you need to place some pillows before, for these patients now is quite easier to set up, comparing with some without Align RT, where only 3 points not enough to give all this information of everything that you need to put in the specific position to have the best agreement between planning CT and the treatment for each fraction. Of course, that with Align RT can also treat patients without immobilization devices. As I said, so Align RT is like a kind of perform like a kind of double check. That means that you can reduce the number of daily imaging repetitions and possibly reduce the number of imaging along the treatment courses, because you are now positioning the patient with 6 degrees of freedoms comparing with the 3-point lasers, for example. This is an example of one patient. In this case, the patient was positioned without a line RT, and after the first cone-beam CT, we detected 10 degrees pitch. That means in this case it was a patient with pillows, and the position was not the same than in planning CT. That means that you need to go inside, correct the patient position, and then perform a new cone-beam CT to confirm if the position is correct. This second cone-beam CT can be spared if you use a line RT from the beginning for positioning. The second case is a re-irradiation of a breast with a small irradiation target. In this case, the first image, the first cone-beam CT, was without a line RT, and was quite difficult to find the perfect match between the two imaging, the planning CT and the cone-beam CT. And we had several rotations to perform, and even with that, it was almost impossible to match the two image. But if you do the positioning, that is second case, for the same patient, if you position the patient from the beginning with a line RT, and then you do a cone-beam CT, then it's quite easier. Then your cone-beam CT only need to give some small adjustment to match with tumor location, but you can directly start the treatment after this small adjustment. So again, for this same clinical case, this patient was treated with a VMAT technique. That means it's a modulated plan where it's important that the patient positioning within a few millimeter accurate to have. In this case, you can see also here below that is the surface of the patient, and the region of interest is also here marked. And I have here a small video where you can see RTTs positioning the patient inside the room. So you have the real-time information, as you see, and the RTT can change in the software between the three different cameras directions. For example, in this case, that we want to have the camera 2, that is the camera from the side where you have the tumor, and this side that is important to match. And the RTT look for the information that you have in the screen, looking for the pink lines that are the reference, the planning CT reference, and then you can make all the small adjustments, couch adjustments, rotations of the arm, everything that is necessary to treat the patients with the best match between the current position and the planning CT. Second example, for example, not only the positioning of the patient in the beginning, but also to monitor the patient along the treatment. This is a case of the patient that because of pain, she was always moving the arm during the treatment. And because of the location of the tumor, it's really important that the arm and the patient and the tumor is in the same location. That means here is important if you left the beam hold on, and if the patient moves during the treatment, the treatment can directly stop. Because there is an interface between the aligner T and the electral linac. So the beam can be held directly when the patients go outside tolerance. So another example in this case, it is a simple, this kind of SRS is simply a whole brain radiation therapy treatment. In this case, that's the patient that is not able to tolerate a mask. Here you can use a line RT to position the head of the patient and monitor along the treatment that the patient have the same position along the entire treatment. That means that you can also correct pitch and roll, and because you have the video function, that is the biggest advantage comparing with the last version. When you have something like a pitch that's incorrect or something, you can directly look for the view and see which direction you need to rotate the patient. As I said, we also use a line RT to treat lung patients in deep inspiration breath hold. Here again, you can use the video function to control the entire treatment, and the video function is even better than the normal video surveillance system, and that means that you can easily see the entire the patient face, and detect if there is any issue during the entire along the treatment. And here the image of the surface of the patient, the ROI that was defined to assess the breathing of the patient and the treatment to irradiate the patient. And so one of the examples of the majority of the cases that we have, breast treated in breath hold. Here again, as you can see here, you can really see everything inside the room. You can even see the panel, the Linac head. You can change between the views to have the video or simply the surface of the patient. Of course, that having the video function, you have always a system in the video function, because if some of the tolerance go a little bit outside, you see why it's outside. For example, if you see that lateral now is 3 millimeters, you can look directly there and see, I saw the patient moving the arm, or something is changing. Of course, that the radiation of these treatments are also performed with the beam hold, and if something goes outside tolerance, the Linac stops directly. Here's an example of the radiation of these patients. So as I said, the first step is always to position the patient in free breathing. When the patient is in free breathing, the RTTs in room confirm if there is any kind of rotations, if the arm are in the correct position, they adjust, they make all these kind of rotations corrections when the patient are still in free breathing. Then is given the information to the patient that she should hold the breath. And when the patient is in the deep inspiration, the table, we do small adjustments with the treatment table corrections to confirm that you have a perfect match between the two surfaces. Then the RTDs give the breathing command 3 times to confirm if the patient is able to return to the same breath hold. So that is exactly here the case, that the patient is breathing normally, and the RTD repeat the information to confirm if the patient is able to return to the same case. And also then when the RTD is outside and the patient in deep inspiration breath hold, is performed the imaging session, KV or MV, and when everything is correct, then we can start the treatment. That means that you have a correlation between the imaging and your surface, because you have a match during the time that you have that the patient is in breath hold. So during the treatment, the beam is hold. When the patient is outside tolerance, you can change between the different views to see if everything is correct with the patient. Normally, we say to the patient that when he is not able to continue holding the breath, he can decide and he can breathe normally. That will be the case in some few seconds. And when the patient is comfortable to restart again, it is a decision of the patient to hold the breath again, and then the Linac will restart the treatment. So here the case that the patient is breathing normally. The Linac hold the beam. And after some seconds, she decided that she is able to continue again. And the treatment continues. So as conclusion, from the what have we learned after 5 months with the Line RT Advance, that a Line RT Advance have really strong implications in our workflow. We are going more in the direction of standardization of workflows, improving patient safety. The workload is slowly reducing. The first fraction, you always need some extra time, but then every fraction gets quicker. We also need to optimize our workflow in the beginning, because more and more patients now are being treated using a Line RT Advance. It's important to keep in mind some challenge. So you need to break some habits. You need to understand that the system is really patient specific, so we cannot define really straightforward workflow without doing any change, because each patient is different. Each breathing, for example, is different. And now you have more data than before. So now you have information not only of the rest itself, but arm. You have a lot of information in real time for every fraction. That is a lot of data. So that you need to understand that how can you use this data to give you more information about the patient and not to confuse yourself with so much data. Thank you very much for your attention. If you have some questions, I'm always available.